Everyone. So I'm going to talk about the hypopigmentation disorders and the hyperpigmentation disorders. First of all, thank you very much for having me today. Um, okay. So the most important objective here in this lecture is to have you all know about the common hyper and hypopigmentation disorders. The hypo and hyperpigmentation disorders are actually a lot, and there are many different conditions, but we don't have all the time to talk about all of them. So I'm going to speak about the common ones that you are likely to face in the clinic. And then after that, of course, automatically you'll be able to formulate a differential diagnosis for pigmentary disorders. And then we will be able to talk about some of the management options. So the lecture is divided into two main categories, the disorders of hypo and hyperpigmentations. I put vitiligo here in the hypopigmentation disorders, but really vitiligo is a depigmentation disorder. Also, throughout our lecture, I'm going to ask you a few questions, so I want people to be interactive, and it's a safe zone, so there's no pressure, there's no judgment at all. First of all, let's talk about the skin structure. So we have the stratum corneum, that's the outermost layer, and then we have stratum granulosum, spinosum, and then stratum basal, or the basal layer. Melanocytes are in the basal layer. They have finger-like projections. These finger-like projections transport melanosomes. Melanosomes are basically vesicles that contain melanin. The keratinocytes basically phagocytose these melanosomes, and then this is why the skin color happens. Um, if there is any problem that affects this whole process, different conditions can happen. If the problem um, basically is a damage of melanocytes, for example, pigmentations will not be there anymore, and this is where vitiligo happens. Let's say, for example, there is a condition that makes the melanocytes hyperreactive or basically active to secrete more melanosomes and melanin. Hyperpigmentation will happen. This is basically the overall general overview of how skin conditions happens in pigmented disorders. Let's talk about vitiligo first. First of all, this is very common condition. We face it a lot in clinic, almost on daily basis. It's usually it comes as patches of depigmentation. These patches can happen anywhere in the body, but for some reason, subhanallah, يعني, it can affect actually the areas that that are heavily pigmented mostly. For example, around the eyes, around the mouth, in the interglottal area, and also in the genital area. The pathogenesis is multifactorial, but mainly it is thought to be due to autoreactive T cells damaging the melanocytes. It can be pruritic sometimes, but usually it's asymptomatic. It also has a positive Koebner phenomenon. Does anyone know what Koebnerization means? Okay, so correct. Koebnerization basically means wherever there is trauma in the skin, the manifestation of the disease itself, like the vitiligo in this case, will be there as well. Perfect. Correct. Yeah. These are just basically different patterns of distributions of the vitiligo. It could be focal, unilateral, or segmental, could be vulgaris, and could be universal, where most of the skin is depigmented. So whenever we see a patient in the clinic, we like to really determine if the patient is going to respond well to treatments or not. And these are some factors that can tell us that. If the patient comes, he's a young patient or she's a young patient with recent onset of vitiligo affects the face, the neck, and trunk. We basically will be more optimistic about the treatment and it's going to work, hopefully. But if the patient has mucosal or acral involvement, family history, colonization, leukotrachea, and non-segmental vitiligo, These are all bad signs, unfortunately. Leukotrichia just basically means white hair around the vitiligo patches. Also, whenever we see patients with vitiligo, it's always good to ask about the associated conditions like thyroid disease, Hashimoto's or Graves' disease, type 1 diabetes mellitus, Addison's disease, alopecia areata, pernicious anemia, halonevi, and uveitis. So for the treatment, first of all, look at the picture on the right side. This is a really good picture of how vitiligo responds to treatment. We can see that pigmentation happens around the hair follicles at first, and then it spreads to cover the whole depigmented patches. So whenever we see these uh, pigmentation patterns, we can tell that the treatment is actually working. The reason it starts with the hair follicles because the hair bulge, which contains the stem cells for the melanocytes, gets stimulated with the treatment, and then the melanocytes will be produced again by these cells. So for the treatments, we have topical corticosteroids, of course. In dermatology, we like to use topical steroids a lot. And then we have calcineurin inhibitors like tacrolimus. It's a really good option because it has the similar effects to steroids without the side effects. And then we have also topical ruxolitinib. This is a JAK inhibitor, basically. The reason we use it here and it works because the vitiligo is also involving the JAK-STAT pathway in their process. And then we have excimer laser and phototherapy like narrowband UVB. Excimer laser basically means narrowband UVB, but it's more concentrated and towards specific lesions. And then we have surgical therapies and depigmentation therapy. We like to use depigmentation therapies in cases of vitiligo that affects most of the skin surface areas. And of course, we have to inform the patients about all the benefits and risks of depigmentation therapy. Now we're going to talk about post-inflammatory hypopigmentation. Really, post-inflammatory hypopigmentation, you'll hear it a lot. Also, you'll hear it a lot about post-inflammatory hyperpigmentation. So any inflammation that happens in the skin can have a sequelae, which is either post-inflammatory hypopigmentation or hyperpigmentation. If there is, like, for example, sebderm, seborrheic dermatitis, or atopic dermatitis, psoriasis, these processes can all produce basically hyperpigmentation or hypopigmentation as sequelae, and this is where basically the term inflammatory hypopigmentation or hyperpigmentation is basically. And then for the treatment of these conditions, usually just treat the underlying condition. These are just some examples of post-inflammatory hypopigmentation. And then let's talk about this. So you see here these two pictures. The first picture is really classic for this condition. We can see hypopigmented, really faint hypopigmented patches in a patient. Looks like this patient is a kid. And whenever we see a pattern like this, hypopigmentation, faint on the face, we think about mostly one condition, but there are many different conditions, of course, in dermatology that can be a mimicker. But in this case, it's pityriasis alba. This is very classic. It is associated with atopic dermatitis most of the time, and it's oval in shape, macules or patches. And for the treatment, we use basically emollients. And sometimes of course, we have to treat the underlying condition. We like to use tacrolimus here as well, sometimes. So here's a bonus question, just to break the routine. Who would like to answer this question? And it's totally fine if you get it wrong, because I actually put some hard questions there. First of all, anyone can explain this? What is going on here? What is this? Mashallah. Correct. A is the answer. I thought this was hard, actually. So this picture is nevus depigmentosus. The name is depigmentosus, but really it's a hypopigmented patch rather than depigmented patch. Nevus depigmentosus is basically a misnomer. It's a hypopigmentation rather than depigmentation. And the key word here is present at birth. Whenever we see this, we can tell that this is probably most likely nevus depigmentosus. Also, one very important thing here, it's totally fine that you'll be a little bit confused sometimes. Is this patch depigmented or hypopigmented? That's totally normal. Even us dermatologists can be confused sometimes. But the best way to tell is using a Wood's lamp. Whenever you use a Wood's lamp, if the area is accentuated a lot and we see a really bright accentuation, this is depigmentation. If the accentuation is not really that much, we call it basically hypopigmented. I liked basically to compare it with the thobe. If you use the Wood's lamp on the thobe, you'll see illumination. So that's another condition. It's basically a teenager color. In this case, we have the distribution really gives it away. Whenever we see this kind of distribution, the picture, oval-shaped hypopigmented patches with scales, fine scales usually, we think about teenager color. We do a skin scraping and we see the classic spaghetti and meatball appearance, which is malassezia furfur in this case. Malassezia furfur, when it affects the skin, it produces azelaic acid. Azelaic acid inhibits tyrosinase. Tyrosinase is basically an enzyme involved in the melanin production. Whenever we inhibit it, the melanin production will be less, and this is why the hypopigmentation happens. Teenager color can also present with hyperpigmentation as well. So it can have either hypo or hyperpigmentation. So there are mimickers of this condition, um, which is why it's important to do scraping. It's important also to check for scales. If there's no scales, we think about other differentials. If there is, of course, no spaghetti and meatball appearance in the scraping, we have to think about other conditions as well. So this is the other condition, which is leprosy. In dermatology, we like to use many different names for the same condition. Leprosy is also called Hansen's disease. It's caused by Mycobacterium leprae. It's a granulomatous disease with an incubation period of 3 to 5 years. It can basically present in two different forms, but there are really a lot of details in leprosy. But let's talk briefly about these two different forms. So if the host immune response is mostly cell-mediated with good cell-mediated immunity, the disease will be contained in the granulomas. And then the Mycobacterium leprae will not be able to proliferate very well. And the manifestation will be tuberculoid leprosy with faint patches, hypopigmented, and also with loss of sensation in these patches. But let's say, for example, the host immune response is not mounting a good cell-mediated immunity, then it will switch towards the humoral immunity. And in this case, lepromatous leprosy will happen with a lot of Mycobacterium leprae bacterial load. The patches will be a little bit more of plaques, actually, thickened. And they'll have also sometimes what we call leonine faces or lion-like face appearance. And the basically the trigger word here is whenever we see a white patch with loss of sensation, think about leprosy. This is another case. What do you think the answer is? D. You guys are really good. Correct. This is D. If I know that was the level, I will put more hard questions. So this is hypopigmented mycosis fungoides. Of course, the biopsy shows atypical lymphocytes, gives it away. Mycosis fungoides, for those who don't know about this condition, is basically not a fungus. It's a T cell, it's basically a cutaneous T cell lymphoma, where T cells can affect the skin, and it's a lymphoma. In this case, it's hypopigmented, but most of the time it's hyperpigmented. We see the hypopigmented mycosis fungoides in usually in younger age groups. Okay, so this is another condition. Now, without options, tell me what do you think this is? It's a common condition. Um, correct. IGH. Correct. Idiopathic gouty hypomelanosis. Houriah, are these only medical students؟
تقريبا يكون في residents في students ما شاء الله.
ما شاء الله. ما شاء الله. Okay, so this is IGH. This is idiopathic guttate hypomelanosis. It's very common. It happens in about 80% of people over 70 years old. It's very benign. You'll be amazed of how many referrals we get for about these basically lesions. It's totally benign. You don't have to do anything about them. If the patient is bothered by the appearance, you can do cryotherapy to stimulate pigmentations in these areas. Okay, what do you think this condition is? Correct. It's scleroderma. Whenever we see the salt and pepper appearance, like the picture here, think about scleroderma as a condition in these cases. Of course, there are other conditions like something called onchocerciasis. It can also cause similar appearance to this one. You can also argue that this is probably vitiligo with repigmentation. I would accept that as a differential diagnosis as well. But from these options, scleroderma is the best answer. Now let's talk about disorders of hyperpigmentation. Okay, what is this? Correct. This is melasma. For melasma, it's basically hyperpigmented patches, mostly present on the cheeks. It can present in the temple areas as well sometimes. Um, It is triggered usually by hormonal changes. Like, for example, in pregnancy, people taking estrogen or OCPs, people who have, sometimes some medications can also does that, like phenytoin. Um, it can be either epidermal or dermal, or it can be actually mixed. And that's usually the case. It's probably mixed. In case if it's actually epidermal, I like really to use chemical peels sometimes, and laser treatments is a good option. But the main treatment is sunscreen. So the most important thing whenever you see melasma is advise the patient to always use sunscreen. But sunscreen is not enough. You have to tell the patient to use a broad spectrum sunscreen that is also physical sunscreen because we have to block the not only the ultraviolet light but also the visible light. The visible light itself can also trigger the melasma and make it worse. So I usually like to advise our patients to use sunscreens even if they are at home, if there is any visible light, because visible light can actually make it worse as well. So that's number one. Sunscreen is the most important thing. And then number two, hydroquinone is a good option in these cases. Retinoid is a good options. And then also there are some different compounds that we use in the different compound creams, like something called triluma or pigmenorms and other options. Okay, let's see. Let me ask you a question. For hydroquinone specifically, or any compounds that contain hydroquinone, we always like to use the hydroquinone for 2 months or 3 months maximum. We don't like to use it for a long time. Do you know why? Correct. Correct. Paradoxical hyperpigmentation because of ochronosis. That's correct. And whenever you don't want your patients to have ochronosis, because when ochronosis happens, it's really difficult to treat. Let's talk about, we already talked about post-lymphatic hyperpigmentation. The mechanism postulated for these conditions is basically epidermal. The melanin activity will increase due to inflammatory markers and also, or mediators, and also the dermal melanosis, which is basically pigment incontinence because of the basement membrane damage, where the melanin will get in the dermis, and then the pigmentation will happen in these cases. Of course, sunscreen is always important. Hydroquinone, tretinoin, azelaic acid is an option. lasers and chemical peels. What do you think this case is? Good. We have different answers. Um, Tuberculoid leprosy. Um, if I give you only the picture on the left side, I would argue that this is probably the case. But in this case, the picture on the right side really gives it away. Whenever we see a picture like this on the right side, we always think about sarcoidosis. Sarcoidosis is a condition that can also present with hypopigmented patches. Um, and in this case, whenever we see a patient with dark skin color, with lesions on the face around the nose, like papules or sometimes even nodules, we think about sarcoidosis. Okay, so let me ask you a different question this time. What is this condition associated with? Perfect. That's one condition, Albright. What else? Correct, correct. What else? There is something important. That's not Bicker's nevus, no. Neurofibromatosis, that's what I was thinking about. Okay, so this is Caffiolin macules. It can present with many different conditions, of course, and it usually presents in infancy and early childhood. Um, it's normal in about 10 to 20% of the population, but whenever we see it a lot and in different areas in the body with specific other things, we think about neurofibromatosis, Watson's syndrome, Noonan syndrome, McNeil-Bright, and others as well. There are many conditions, but I only included these. Okay, what is this? Perfect. What medication are you thinking about? Amiodarone, correct. Correct, perfect. Algeria is a good answer. Really good answer. Okay. So it's drug-induced hyperpigmentation from amiodarone. And we have actually many different types of drug-induced hyperpigmentation. Okay, what is this condition? Okay. Correct, lichen planus pigmentosis. It's lichen planus pigmentosis. Pellagra is a really good differential. Pellagra is a really good differential here. This is lichen planus pigmentosis in this case. And it's not very common. It's a type or a variant of lichen planus, favors skin type 3 and 5, 3, 4, and 5. And the etiology is usually unknown. Uh, the treatment for lichen planus pigmentosis is really not easy. We try different treatment methods, but um, there is no really well-established treatment for these cases. Okay, what do you think this condition is? What's the other name for ashy? Correct, ADP. So teenagers color in this case, not really classic because first of all, we don't see scales here, and also the pigmentation pattern is a little bit different than what we like to see in teenagers color. Teenagers color, you'll see a little bit more discrete macules and patches, but in this case, we see different macules and patches coalescing together, forming basically this network pattern. In this case, it's called erythema dyschromicum persistens or ashy dermatosis. The treatment also for EDP is difficult and it's not easy. Um, I did put here in the slide that there is no effective treatment, but for a question answer for a quiz answer, what is a good treatment that we like to ask about as a high yield treatment option? What would you think about in this case? Correct, correct, clofazimine. Clofazimine is a good option. It's used for leprosy, but it's also effective for EDP. Okay, what do you think this patient has? That's the correct answer. It's either A or B. It's either A or B. Both answers are correct. Shiitake mushroom ingestion and also bleomycin-induced flagellate dermatitis. What other condition can give you flagellate dermatitis? Does anyone know a third condition? Not atopic dermatitis. Correct, dermatomyositis. What else? There is something else as well. Okay, sometimes Still's disease can cause that. Paraneoplastic, psychological. Still's disease is can cause flagellate dermatitis. Okay, time for Kodachromes. Um, Unfortunately, I did put some simple Kodachromes here. If I know that this was a level, I would challenge you further. But I like to use the term Kodachromes. We use it a lot in back in my residency. Kodachromes basically means just pictures with your answers. What do you think this picture is? What's the diagnosis? Be more specific. What kind of leprosy? What type of leprosy? Lepromatous leprosy, correct. That's the leonine phases. What is this? Halonivus, correct. Correct. What is this? Vitiligo. What about this? Okay. All of these answers are great answers. In this case, my top two differentials will be lichen planus pigmentosus and also ashy dermatosis. So both differentials are acceptable and are really good differentials, but really most of your differentials are great. What is this condition? That's easy. That's melasma. What about this? Correct. Pellagra is a really good differential as well. Perfect. Scleroderma is a good differential. I would put it in the differential, but not my top differential. It's lichen planus pigmentosus in this case. What about this? Pityriasis alba. Correct. Thank you very much. ما شاء الله يعني I had actually I lowered my expectations. I thought these questions will be hard, but mashallah, you really killed it. And next time, inshallah, I will put some more questions that are probably gonna be more challenging.
يعطيك العافية دكتور سعود.
الله
Really
يعافيك.
wonderful lecture ما شاء الله. It was very informative وإن شاء الله بإذن الله أكيد الجاية أكتر بإذن الله.
ان شاء الله ما شاء الله تبارك الله يعني جدا جدا المستوى عالي.
ما شاء الله تبارك